Good evening and welcome to Close to Home, Advanced Breast Cancer Care in Tallahassee, a virtual discussion hosted by Tallahassee Memorial Healthcare, your hospital for life. With 1 in 8 women receiving a diagnosis in her lifetime, breast cancer eventually hits close to home for nearly everyone. Fortunately, the Walker Breast Program at the Tallahassee Memorial Cancer Center provides the region's most advanced comprehensive care close to home. The Walker Breast Program operates like a big city cancer center right here in Tallahassee, helping to shorten the time it takes for patients to go from diagnosis to treatment. The Walker Breast Program also brings cancer care specialists together under one roof, meaning patients receive high-quality, multidisciplinary treatment at one location without the need to schedule appointments all across town. Good evening, everyone. I am Alicia Hill. I'm the Director of Communications and Marketing for the Tallahassee Police Department, and it's my absolute honor to host this panel discussion again this year. It's always wonderful conversation and so necessary for the folks in our community to understand that there are some wonderful, talented, educated people right here in the community doing everything that they can when people receive those diagnoses, and also making sure that the educational component is there as well. So I am grateful to be your panel moderator this evening, and I'd like to introduce you to our incredible panelists of physicians here at TMH and everyone with us today, bringing a unique perspective when it comes to breast cancer care. So our panelists include Dr. Shelby Blank, the Medical Director of the Walker Breast Program and General Surgeon at TMH. Dr. Shermeen Everidge, a fellowship-trained breast surgical oncologist at TMH. Dr. Janine Silberman, a medical oncologist and psychiatrist at TMH. Dr. Alfredo Paredes, a plastic surgeon at Tallahassee Plastic Surgery Clinic in TMH. And Dr. Yusuf Syed, a radiation oncologist at TMH. I want to thank each of you for joining us this evening. Many of our viewers, they submitted questions online ahead of time, which I'll be sharing with the panelists. And we also want to encourage anyone that's watching or listening, wherever you are, to make sure that you can submit your questions as well. Please use the Q&A feature here on Zoom to submit them, and we'll be monitoring them as they come in to hopefully get to your question and have you get a chance to talk with the experts and answer them in real time. So without further ado, we'll go ahead and get things started. You know, just like with anything, we want to start at the beginning. That's where a lot of people have most of the questions when it comes to breast cancer screenings and diagnosis. So I'm going to jump right in and ask Dr. Blank to talk a little bit about the importance of mammograms and detecting breast cancer early.
Absolutely. I mean, certainly in October, it shines a light on the importance of breast cancer awareness and early detection. And really, in today's world, many of the breast cancers that we find are not palpable, nothing anyone would notice, and are really only found on imaging. And that is why, you know, finding these at an early stage obviously is quite desirable. So mammograms on a regular basis are super important. These are certainly discussions that you have individually with your primary care doctor, because different people have different risk factors that may change their screening recommendations. But for most people, having an annual mammograms, for most women, starting at age 40, having an annual mammogram is what most of the thought leaders in breast cancer recommend. For people who may be high risk for other reasons, those are discussions to have kind of on an individual basis. And then having a mammogram annually after that. For how long is really also an individual discussion. I think for people who are leading healthy, robust lives, you may continue to be screened to quite an advanced age. If people have a lot of comorbidities and that would prevent addressing their breast cancer, then maybe a mammogram is not so helpful for them. But certainly, you know, being aware, you know, looking for any palpable areas, but by far, mammography is our best weapon at finding these at an early stage.
And Dr. Blank, what are some of the signs and symptoms women and men should be looking out for?
So I think certainly noticing any changes, skin changes, certainly a palpable mass that's new or different, a mass that you may notice under your arm, discharge from the nipple, particularly that has any blood, so is red or brown tinged, are all things that would be things that would need to be checked out and could be red flags to indicate a problem.
And a lot of times you hear doctors talk about self-exams and just noticing when things are different. Talk about the role that self-exams can play in early detection.
So I think some of that is changing. For most people, doing a breast self-exam is a very difficult process. You feel a lot of things. You don't know really what's concerning. There's not a lot to compare it to. So having an idea of what you're actually feeling for when you're a patient can be very difficult. So we've kind of substituted the idea of breast awareness, which basically means know what is normal for you, such that over time, if something crops up that's new or unusual, that you would recognize that. So checking yourself on a regular enough a basis that you know what your normal baseline is. So if something does show up, you will be aware of it at an early point.
All right. Now we want to switch into the Walker Breast Program and the treatments available in Tallahassee when someone receives a breast cancer diagnosis. Dr. Blank, TMH developed the Walker Breast Program and Breast Clinic to streamline the patient journey from diagnosis to undergoing surgery and receiving further treatment such as chemotherapy and radiation therapy. Tell us about what this experience looks like for patients who come to TMH's Walker Breast Program.
So no, thanks. This is obviously a passionate topic for me and for I think most of those on this panel. What we realized is that it was a big frustration for patients that they had to spend a lot of time and effort when they were diagnosed with a breast cancer to see all the people that would be part of their team. And so the idea was to make that process as seamless and as easy on the patient as we could and do it in the most timely fashion. And so that sort of has been a process of evolution, but currently we've kind of evolved a weekly new diagnosis breast clinic so that patients who have a new diagnosis of an invasive or a pre-invasive breast cancer are able to come to the cancer center to see me or one of my partners, Dr. Everidge, Dr. Howard, and talk about their diagnosis. And then in real time, while they're waiting at that visit, their entire case is reviewed by a multidisciplinary group where we look at imaging, we look at pathology. We have our medical oncologists, radiation oncologists, genetics experts. Everybody kind of reviews their case individually, and then they're able to meet with whatever providers will need to participate in their care. And that may be, they may be looking at surgery up front. They may be looking at radiation questions. They may be looking at chemotherapy prior to surgery. So that gives us the ability to look at all of those options and have the patient go ahead and meet with those providers so that their plan of care can start immediately. We also have a great link to our plastic surgeons like Dr. Predis, who are able to see patients sometimes on the same day, but certainly within 24, 48 hours. So the reconstructive questions can be addressed. So the idea is pulling that all together and giving patients hopefully a seamless experience where they're getting as much information in a single visit. As we draw people from further and further distances, that becomes even more and more important.
Dr. Blank, thank you. Dr. Everidge, you recently joined TMH as the region's first fellowship-trained breast surgical oncologist. Can you explain to us what exactly a fellowship is and what that level of training means for breast cancer patients in our community?
Yes, so a fellowship is usually an extra, for general surgery at least, an extra 1 or 2 years of training and kind of focusing in on a topic or a specific interest. Mine is breast surgical oncologist, but or oncology, sorry, but there are other fellowships that exist. What that means is that I spent an extra year pretty much living, breathing, eating, sleeping, everything regarding breast cancer and its treatment. So I worked specifically with breast surgeons and saw the different types of surgeries that MD Anderson had to offer. I worked very closely with the medical oncologists that focus solely on breast cancer treatment, as well as the radiation oncologist, and got a behind the scenes look, if you will, on their treatment aspects, how they contribute to the treatment of breast cancer. In residency in general surgery, you do get a little bit of that exposure, but this was kind of an in-depth exposure. We follow patients kind of closely. We have our own patients that we follow closely. There was one day where I would follow a patient to all of her imaging visits, actually. We learn about the community aspects of having breast cancer and where patients could get prosthesis and things like that. Just a lot of kind of getting a whole view on the treatment of breast cancer.
All right. And when you talk about treatment, we want to shift into that as well. Dr. Silverman, most people have heard of chemotherapy for cancer treatment, which is essentially taking medications to kill cancer cells. Could you tell us more about immunotherapy and other innovative treatments being offered at TMH for breast cancer?
Sure. So breast oncology, fortunately, is rapidly advancing. And by that, I mean, we're using a lot of new targeted agents. You mentioned immunotherapy being one of the more notable ones, but there are many others as well that target molecular pathways. All medications have side effects, but they have less side effects than the conventional therapies, which are non-targeted. So that's meant progress for our patients, both in terms of better response rates and less toxicity. Because we're constantly weighing the pros and cons of treating people in terms of risks and benefits to them. We're also changing the way we sequence our treatments. So Dr. Blank mentioned that we're giving chemotherapy up front, meaning prior to surgery. That's sometimes called neoadjuvant chemotherapy. And that's why the multidisciplinary breast conference and clinic is so important, is to make sure we identify those patients and put our heads together and come up with a plan early on in their treatment formulation. So those are some of the new advances. There are many more coming down the pipeline, with breast cancer being as common as it is, approximately 1 in 8 women affected in their lifetime. We have a lot of patients that we can look at in terms of clinical trials, which is largely why we have these advances and less so in some other areas of oncology.
It's so incredible to think about the advances in technology and, how far we've come, and looking at how far there is to go. Dr. Syed, radiation therapy has long been used to kill cancer cells and shrink tumors. How has radiation therapy evolved over time, and what does this treatment look like today compared to the past?
Yeah, great question. It's an exciting time to be a radiation oncologist in the breast cancer space. Treatments, I would say, have evolved quite a bit in recent years. The focus now really is on delivering the right amount of radiation to the right patients. And a lot of times that means minimizing the amount of radiation that's used while still achieving the same survival outcomes. Historically, if we go back 20 or 30 years, most women would reflexively get 6 weeks of adjuvant radiation therapy, for example, after a lumpectomy. We've now gradually pared that down. We will still do some of those longer courses in women with lymph nodes involved, but for women that don't have lymph nodes involved at the time of diagnosis, oftentimes we can condense that treatment into 3.5 or 4 weeks. And for a subset of really low-risk patients, we can sometimes further condense that down into 5 individual treatments. So a lot of changes recently. And then building upon that, there's some exciting data that we're expecting over the coming years. One clinical trial, the MA39 trial, that's going to be looking at using some of our molecular profiling tools to guide radiation treatments and maybe find ways of minimizing radiation treatments in a thoughtful way using molecular profiling, which we're now using for guidance of chemotherapy for some patients. Another trial, the Supremo trial, that's looking at what I would consider to be intermediate risk patients after mastectomy, and really sharpening the pencil on which patients benefit from radiation to the chest wall after mastectomy. So again, exciting time.
And when you talk about, exciting time, the technology, the advances, TMH is in the process of upgrading its linear technology. What does this mean for patients who undergo radiation treatments?
Yeah, so I think TMH has always been at the forefront. I think the department has always strived to deliver really cutting edge treatments. But we're thrilled that the hospital has decided to invest a lot of money into our equipment. They're upgrading all 3 of our linear accelerators, which are the big, fancy, expensive machines that are used to deliver radiation. The first one is already in service. That was commissioned a few months ago. Our second new machine is coming online next month. And our third one will be coming online sometime next year. Again, I think we've always done a great job to deliver high quality radiation for our breast cancer patients, but this really allows us to take it to the next level, to continue to offer cutting edge radiation treatments for all of our cancer patients and certainly for our breast cancer patients.
Incredible. Thank you so much. I also want to remind anyone that's watching, if you have any questions, especially as we're going over certain topics, please don't hesitate to leave a question in the Q&A box that you can find on your Zoom link. So feel free. We'll get to those as soon as we get an opportunity to. Dr. Paredes, can you talk a bit about reconstructive surgery following a mastectomy and your role in the process? Are all patients who undergo mastectomies candidates for reconstruction?
We get involved both with lumpectomies and mastectomies. With lumpectomies, particularly for women who have larger breasts, who've somehow always thought of having a breast reduction, we now do something called oncoplastic reductions, where we team up with our general surgery colleagues and do a reduction at the time of the lumpectomy, and that allows them to get radiation later. For mastectomies, we also get involved with our general surgeons and either offer reconstruction immediately, meaning on the day they get their mastectomy, we would get involved with starting the process for reconstruction. It is done in stages, which is a common misconception that you'll just wake up with everything completed. It does take 2 or 3 rounds of surgery. Sometimes we'll delay patients, either due to things about their cancer or their health, that it might be better to wait a few months to allow everything to settle before we start the reconstruction.
Okay. And so if someone doesn't want to undergo reconstruction right away, what are some of their options?
So there are women who come in and not sure if they want reconstruction. And so they'll go ahead and go through their surgery. Let's say they get a mastectomy. They might go ahead and meet oncology and radiation oncology and go through those therapies if they need them or not. And then they'll come back to us for reconstruction later. So the good news is that reconstruction can be done either starting with a mastectomy or it can be done later. I do think that sometimes patients are overwhelmed with the amount of information they're getting, and the idea of reconstruction just seems to be a bit too much because it's adding on or piling on more surgery than they were really thinking about doing, and they really want to concentrate on their cancer, and that is absolutely perfectly okay. But the good news is it doesn't burn any bridges to come back later and start a reconstruction later, so there's nothing to hold you back from doing that. There are some patients that have some medical issues that might not make them the best reconstructive candidates. There are some patients who are better to have a lumpectomy than a mastectomy, or vice versa. So there's that whole process of taking a history and talking to patients, seeing what their medical history is. Things like, are they actively smoking now? Have they had radiation in the past? There's different things that we inquire about that would make a decision whether we think reconstruction should be done now or later. Most people end up being reconstructive candidates. A lot of things that might not make them immediate candidates are modifiable risk factors that we can then change and then sort of help make them a better reconstructive candidate later.
All right, perfect. Dr. Paredes was talking a lot about when people are deciding whether or not they're going to go into reconstructive surgery, that there's just a lot going on. That speaks to the mental aspect of things. Dr. Silberman, you're also a psychiatrist. Tell us about the role mental health plays during a breast cancer diagnosis and what resources does the TMH, the Cancer Center, and the Walker Breast Program have to help patients.
Thank you for bringing that up, because it's an important and often overlooked aspect of both the active treatment and the survivorship for breast cancer patients. I approach it, obviously trained as a psychiatrist, it's in the forefront of my mind. So we take a review of systems when we meet the patients. We ask actively, what are you experiencing? Are you anxious? Is your mood low? Sometimes it's just them reacting to the diagnosis, which is understandably stressful. But other times we do make a diagnosis of clinical depression, an anxiety disorder, and so forth. It's really, our patients are sort of a slice of the general population of our community being as common as it is. So you also see patients that come in with a diagnosis of a mental health disorder. So we first try to identify it. For my patients, I often manage their psychiatric medications. Unfortunately, I cannot give psychotherapy in the time that I have with them, but we do have licensed clinical social workers available at the Cancer Center who take on that role and give supportive psychotherapy. We have breast cancer specific navigators that meet with all of our patients, both at their initial meeting, consultation, in the multidisciplinary clinic. They're very present, but also a follow-up. So they check in with them frequently, and they're available for all of their needs, whether it's, anxiety, pain, questions, and they serve as a point of contact to help point the patient in the right direction and get those questions answered. We also have support groups. During COVID, they sort of became much less available and went to Zoom and Teams, but they are now back live. So our breast cancer patient navigators are very happy to connect patients with those groups.
And I also want to open that question up on the floor. Is there any other doctor that wants to weigh in, just talking about the mental health aspect of a breast cancer diagnosis, not only on the patient, but the family as well?
I would say, I think one of the hardest things is oftentimes the person who has the new diagnosis is, the matriarch of the family. They're the caregiver, and they have spent their, the bulk of their time either taking care of their kids, their grandkids. And so they're often sort of the keystone of what holds the family together. And so as you rightly point out, this sort of rattles not just the patient with the new diagnosis, but the entire kind of family. So giving that patient permission to sort of step back, leave some of the heavy lifting to other members of the family, let them be the person who's taking care of for a while is a hard time. It's a hard adjustment for them. And so I think that's one thing that we try to do is encourage them to step back. We all have had patients who don't want to let their families know because they say, I've got this, I can do this on my own, and I don't want to worry my family, I don't want to worry my kids. But this is a time that, now it's time, to lean on your support group, your support staff and your family. So encouraging people to do that and take advantage of not just the resources that their family and loved ones can offer, but also the things that we have within our organization.
Thank you, Dr. Blank. Dr. Paredes, and really, before I get into the question, we know how big of an impact lifestyle can have on a cancer diagnosis. So talk about the impact tobacco use has, not only as a risk factor for breast cancer, but also during the recovery process.
Yes. So, and the best word to use is really nicotine use, because today tobacco gets used in a lot of different ways. So you can smoke nicotine with a cigarette or cigar, you can vape it, which is a commonly misunderstood source of nicotine in the body. So vaping is an issue. Nicorette patches, Nicorette gum, chew, dip, snuff, any way you get nicotine into your body can have a negative impact on how you heal. The lumpectomy, especially the mastectomy, that we create these large skin flaps that need a lot of blood supply, and nicotine actually reduces oxygen supply to the skin. So a nicotine user at the time of the mastectomy has a much greater risk of having tissue die or skin loss. They have about 4 to 8 times higher rate of infection. And those are things that we really want to avoid, because understand, after this mastectomy, you might be offered chemotherapy, you might be offered radiation therapy, and those additional therapies that are meant to triple team up on that cancer might get delayed by complications that result from the surgery. So I advise patients, the moment they've heard they have a breast cancer, if they smoke, if they use nicotine, they need to stop immediately, so that as the couple of weeks go by while you're meeting other doctors, your body can at least start flushing out that nicotine chemical from inside. We don't find that marijuana use actually complicates surgery. So it is an alternative for people, and they often misunderstand that smoking in general gets used like that. When we say smoking, we mean nicotine use, not marijuana use, because there are so many patients that use marijuana for medical reasons, for pain and or anxiety or things like that. That won't actually affect surgery. But as soon as you stop, every day that goes by nicotine free can actually have a positive impact on healing. Just days and weeks will make a difference.
That's incredible. And vaping, a lot of people, you're seeing it more and more, especially among younger people. Are there misconceptions about the impact that it can have on your health overall, or do you think people are informed about it?
No, I think unfortunately children are highly uninformed about the effects of vape. I've had these discussions with my own kids and their friends. There's a big belief system that vaping is the safe way to smoke, essentially, because you don't get the tar or the burning of the paper or the leaf. But actually, a lot of studies find that most vapors will use more nicotine than they would if they actually smoked a pack of cigarettes, because they'll often go through 2 or 3 cartridges in a day. That's a lot of nicotine being inhaled in one day. So sometimes you don't get quite the understanding of how much nicotine you're putting in your body. About the one benefit I have seen from vaping devices is if you purchase the cartridges that decrease the dose of nicotine over a few week period, it's actually been shown to be very helpful to wean people off of using nicotine or cigarettes by simply decreasing the dose in the nicotine cartridge that comes inside the vapor. But that's a decision the patient has to make and consciously make, because when you buy it at the store, it's always got the max amount in the cartridge.
And what resources exist to help people quit? I know you talked about the vaping and it having something to kind of help wean you off, but what are some other resources?
Well, we know that the TMH Cancer Center has resources available for patients. There are places that offer nicotine replacements, which again, lozenges, gum, Nicorette patches, they can help over the long term. But again, it's still applying nicotine into your body when you put a patch on your shoulder. So the reality is, I tell cancer patients who just got diagnosed, you really need to stop cold turkey today. Having said that, there are some resources available through the American Cancer Society, through the TMH Cancer Center. There are medications that can be prescribed, like Chantix, Wellbutrin. Those are things that we can try to use to help cut the crave, because it's easy for me to say, hey, just quit smoking or quit your nicotine. At the time of a cancer diagnosis, it's such a stressful time that oftentimes I'll see people actually increase their smoking and other nicotine use because it's a stressful time period. And in a sense, it's a soothing mechanism. So I fully understand that. But it's important they also understand what it's doing to their body in terms of healing.
Absolutely. We also want to talk about recovery, survivorship, and beyond. Such incredible topics to make sure that we get onto. Dr. Syed, what does survivorship look like from a medical perspective? And at what point do you consider someone in remission or cancer-free?
Yeah, good question. So one thing to keep in mind is that when patients are under active treatment, it's a very busy time. They're meeting oftentimes, multiple different doctors. Some treatments are delivered concurrently, simultaneously, and then they complete their treatments. And a lot of patients just struggle with the notion of what comes next, and what do I do now that I don't have daily or weekly appointments with doctors? So the important thing to remember is that survivorship is multidimensional. And we want to make sure as a cancer center that we're there for our patients, even after they've completed their active treatment. We're there to support them in all efforts afterwards. So, the components of survivorship that I think of, screening, of course, is an important thing. Dr. Blank talked about that earlier. They should resume an appropriate screening regimen under the direction of their physicians. And then aside from that, monitoring some of the side effects, the long-term side effects of the treatments that they've received, or side effects associated with any adjuvant treatments that they're, receiving after surgery, radiation, and so forth. And then we focus on things that are not, specific to breast cancer. So quality of life. We go back to some of the basics, working with patients on diet and exercise, just resuming their normal daily activities, getting, re-engaging with life, their family, hobbies, work, all of those things. And then resuming normal health maintenance activities, following up with their gynecologist, following up with their primary care doctor, completing those other unrelated, health screening activities, whatever those might be. So that's really how I approach survivorship with patients when I meet with them in the years after treatment. As far as when do we declare patients cancer-free or in remission? It's a complicated question. Patients ask me this all the time, and I give kind of a long and probably somewhat unsatisfying answer. But we know that if and when breast cancer recurs, it tends to recur earlier on in the years immediately after their active treatment. And so we adjust our surveillance methodologies accordingly. They'll visit us more frequently for physical examinations. We'll keep a close watch on those mammograms. And we'll kind of start to space things out as the years pass by. We have this arbitrary metric of 5 years. I'm not sure that that's really, rooted in piles and piles of data, but, generally speaking, if a patient has made it out into that range and they're still cancer free, we know that the likelihood of that original cancer coming back is quite low.
All right, thank you so much. We have an incredible question from the audience. This is something a lot of people probably want to know. What can we do to protect ourselves from getting breast cancer? I know that's probably a multifaceted answer, but they also wanted to know what preventative measures can be taken. That question is for anyone.
I can start off with this. So some of the modifiable risk factors that are kind of high on the list for developing breast cancer are one, obesity. And so we know that breast cancer is linked to our exposure of estrogen, and even in the postmenopausal setting, our fat cells create estrogen. And so actually reducing the amount of fat we have can actually reduce our risk of developing breast cancer. And having an active lifestyle in general decreases our risk as well. Other things that, things that we can't really adjust for, but having children, breastfeeding, things like that we can't really adjust for. But just knowing that if we did do those things, those are actually things that can actually have a positive prognostic indicator or as it relates to developing breast cancer.
I think and Dr. Silverman can probably speak to this as well. They're probably not really indicated for the general average risk patient, but there are medications for patients that are particularly at high risk for developing breast cancer. We call this chemo prevention. And so it's not chemotherapy in the way that many people think of chemotherapy, but these are pill therapies that are effective in high risk populations or people who have had high risk findings on pathology in the past that can work to reduce future risk of breast cancer.
Okay. And Dr. Everidge, talking about those risk factors and people doing what they can to maintain a healthy lifestyle. I know there was a time where people would just think the absolute worst when they would get those diagnoses. With medical and technological advances, what does the general prognosis of the disease look like now compared to the past?
Yeah, so actually 5-year disease-free survival is kind of one of the figures we look at. And for one of the most common subtypes of breast cancers that are diagnosed now with early screening detection, that's about 94%. 94% of patients that are diagnosed with these early kind of most common breast cancers we see are surviving longer and without the recurrence of breast cancer. So that number is pretty high. And I think the biggest thing that we can contribute that to is early screening with detection of breast cancer early to open up the doors for a wider range of therapies that can help reduce the risk of recurrence.
Thank you. Before we move to the questions from our audience or more questions from them, Dr. Blank, please tell us about any additional resources TMH has for regular proactive breast health care.
So certainly, I think the most robust is going to be our mammography unit. There are a number of different women's, imaging units and centers throughout the city and the surrounding area. So if you aren't on a regular screening mammogram program and you need a mammogram, TMH can help you with that. Or if your primary, wherever you choose to get your mammogram. But certainly that's a robust program for screening. We have genetic counseling resources. So for folks who have an extremely high risk with multiple closely related family members, particularly diagnosed at an early age. And by that, I mean, someone who's diagnosed in their late 20s, 30s, early 40s with a breast cancer or ovarian cancers. Those are people that maybe need some additional counseling and potentially testing for genetic abnormalities. And we have the ability to do that. As Dr. Silberman mentioned earlier, we have breast navigational services. So that kind of is support for families as well. But for general population of someone who does not have breast cancer, but wants to make all the healthy choices to keep from developing that, I think certainly mammography and any genetic assessment is helpful.
Another question we have from the audience, does TMH have any programs to assist underinsured or non-insured patients seeking care for breast cancer?
So yes, there is a role for anyone that needs care for cancer at TMH will be taken care of. Whether that means relying on charity services, donors, the TMH Foundation is very helpful, payment plans, helping patients get set up with an insurance plan. There's all different ways to approach it, but please do not seek care because you lack funding or lack insurance. You will be taken care of.
Thank you. Does having breast cancer put you at increased risk for other types of cancers? And if so, which ones?
Well, I would say that having a diagnosis of breast cancer increases your risk of developing further breast cancers down the road. There are familial cancer syndromes, as was touched on earlier. All cancer is genetic, but not all cancer is familial genetic, meaning passed down from generation to generation, at least that we understand currently. We do have a clinical genetics center. We refer patients if they meet certain criteria for testing. Clearly, if somebody has a clustering of breast and ovarian cancer in their family and a breast cancer diagnosis at a young age, those patients will be referred.
And just to add to that, just to add on, in addition to these, heritable components, some of the treatments that breast patients receive, for example, radiation chemotherapy, there is a small but not insignificant number of patients who develop a secondary malignancy. We discussed this extensively with patients at the time that we see them. Overall, the benefits of these treatments far outweigh and exceed a very small risk of secondary cancers associated with some of these treatments, but something to consider.
Okay. And Dr. Paredes, after women undergo breast reconstruction surgery, how often are they following up with their plastic surgeon? And is there anything they should be or they should expect in the months and even years following surgery?
That very much depends on the type of reconstruction that they've had. If they end up with, let's say, an implant-based reconstruction, there are some FDA protocols for some imaging of the implant. We'll typically recommend an MRI to be done about 5 years after the implant was placed and every 2 to 3 years thereafter. That will look at both the implant to make sure it's staying intact, but it also looks at the surrounding tissues. Because when you've had a double mastectomy, you won't have mammograms. If you have a single mastectomy, you won't have a mammogram on that side. So MRIs come into play later. Patients will, once they're, they'll see us for about a year and a half to sort of get through all the stages. And sometimes there's some little touch-ups and additional procedures that we do to kind of help perfect things. But once that year and a half is over, sometimes people come back every 2 or 3 years just to check in with us. But once you hit your 5-year benchmark and your reconstruction is doing well, there can be limited visits after that.
Thank you. And I want to remind everyone who's tuning in, again, if you have questions for our doctors, please feel free to ask away. A lot of great information here being shared. The next question we have is breast cancer on the rise? And if so, do we know why it's on the rise?
Dr. Silverman, you can, I think the answer is probably a resounding, we don't know. I think that certainly I feel like that we're seeing more and more cases, particularly at a very young age. And is that because we are, has it always been there and we're just better at detecting it now? Or is there really more, a higher incidence? And I don't think anybody quite knows that now. And if it is a higher incidence, why that is. It may be just that our imaging detects things now that we wouldn't have been able to detect in the past. So I'll throw that open to the rest of the panel and see what their thoughts are.
I absolutely second the way you did a nice job answering that. Yes, it seems like we are seeing a lot more breast cancer and at an earlier age. There's no doubt about that. It is probably, this is going to sound unscientific, but it's probably a complex interplay of environmental and genetic factors that we still need to ferret out, which further emphasizes the fact that there are lifestyle modifications that people can make that will reduce the risk. We now know, and this is very evidence-based, that regular vigorous exercise reduces your risk of developing breast cancer recurrences. So by that, I mean 4 to 5 times per week, 45 minutes of cardiovascular exercise, and you will benefit in spades, because it'll reduce your blood pressure and your blood sugar, and it'll keep your bones strong and healthy. You sleep better at night, you're less anxious. So a multitude of benefits from regular exercise. Also, a farm to table type diet, lacking preservatives. A Mediterranean style diet is a great one. Avoid fried foods. And these are things that we talk to our patients about routinely, just important, sort of often overlooked lifestyle changes that matter.
This next question could be for Dr. Blank or Dr. Everidge, or anyone else who wants to jump in. Many women may hear the words breast cancer and instantly think of mastectomies. Do all women diagnosed with breast cancer need to undergo surgery?
I'll start and let Dr. Everidge finish. I would say that most women who are diagnosed with a breast cancer will need some type of surgery at some point in their treatment pathway, but it does not necessarily, and in fact, the vast majority will not need mastectomy. Sometimes mastectomy is a choice, and that choice may be because of other high-risk factors. It may be just personal preference, but I would say the vast majority of patients that we diagnose are a great candidate for breast conserving therapy or lumpectomy, and actually have a lot of options open to them. Dr. Everidge, I'll let you chime in.
That was perfectly put. And the reason why breast conserving therapy is an option for a majority of these women is because of early detection. We're able to catch these at smaller sizes to offer a smaller, a less morbid surgery to treat that cancer equally.
All right. And when we talk about, the role that your families play, talk a little bit about the support and how important it is to have, the support of your families when you're going through this. And, I know that there's a lot of different programs out there to help with the mental health aspect of it, but anyone can jump in to answer that question for those watching.
Well, the treatment is intensive, and you can tell by looking at the panel, there are a number of different medical specialties, surgical specialties that are represented here. So, we treat breast cancer very aggressively, and for good reason, because most of these patients we can cure. So they have a lot of appointments and procedures, and there's a lot of testing, and there's a lot of stress associated with that, and a lot of unknowns, which is what we're hoping today to help demystify. So, upfront is sort of front loaded, and then they start coming in less frequently after treatment, but they're still in sort of a recovery mode for a long time. Many people don't actually have time to really process what they've been through, and that takes some time, and that's the survivorship aspect of it. So they need support for all those reasons. It's an intensive pathway.
It is. And I would say not everyone has the same, when we say family, we sort of think about people that you're related to, but everyone's family is different. And they may find that their support system is a friend, a coworker, a neighbor. It may be someone they meet as they go through their treatment. I have a number of patients who, while they're going through radiation or while they're sitting in a waiting room, they meet sort of their cancer buddy, and that becomes their support system or their their family as they go through this journey. So I think that that family support can come from a lot of different sources. There are great support groups both in the community and through Tallahassee Memorial. There's, again, on our website, there's information on that. There's a local group called Joanna Francis Living Well. That's a great support group and does a lot of interesting and fun things, but also offers support, both financial and just from an emotional and well-being standpoint. So there is help out there. And so if anyone is struggling with this pathway and with, needing help, reach out, because there are a lot of people there that want to help.
And if someone does have a family history of breast cancer, are there any extra measures that person could or should be taking?
Well, when they come into contact with one of us, we would take a family history, and based on that information and their own personal history, we might make a referral to the genetic center, where they would dive even further into that family history and potentially do genetic testing.
I'll add to that and say that there are risk models that exist out there that I use in my clinic often to assess your risk of developing breast cancer. And based off of that, we can offer high-risk screening versus offering risk-reducing medications as well, involving the medical oncologist.
And when it comes to screenings, do you recommend ultrasounds in addition to mammograms for women with dense breast tissue? It seems more and more women are being diagnosed with breast cancer and it wasn't discoverable on mammograms. Another user question.
So I think that the radiologists do a really good job at kind of picking up on these patients with dense or really dense breast tissue. And they usually make recommendations as to what adjunct imaging is needed, whether that be ultrasound or MRI. In the breast world, we use kind of the trifecta of mammogram, ultrasound, and MRI in different settings, depending on the woman, depending on the breast density, and also depending on what we're looking at. Are we looking at something that was palpated? Maybe ultrasound is better for that versus it's not just kind of an all breast dense breasts get an ultrasound added on.
Okay. What is the survival rate after a stage 4 diagnosis?
That's an interesting question. I saw 2 patients this week who had metastatic breast cancer that have survived, have been treated definitively, and have no evidence of disease recurrence. One is out maybe 6 years, the other one a little bit longer than that. So similar to colon cancer, it's one of, and head and neck cancer, it's a unique sort of cancer in that stage 4 patients can be cured. So, please do not avoid going and seeking medical attention because you think that your cancer is beyond help or that you don't have the resources to address it.
Dr. Silverman brings up a good point about misconceptions oftentimes that people can have that might make them delay getting the treatment that they need or not knowing the questions to ask. What are some common misconceptions that any of you see in your particular area of expertise that you wish more people just asked the question about?
Well, I think radiation therapy in general tends to be kind of a black box for a lot of patients. Maybe they've heard stories of a friend or family member undergoing radiation and perhaps for a completely different type of cancer. And then that shapes their view of what radiation entails. We addressed a question earlier about mastectomy versus breast conserving therapy and what is the role for mastectomy and so forth. One thing that patients learn when discussing treatment options is that for most patients who undergo lumpectomy, breast conserving surgery, radiation therapy is recommended afterwards. And I would, strongly encourage patients, if they have concerns about radiation therapy, or if they find that that's kind of a deciding or influencing factor in which type of surgery they choose, I strongly encourage them to talk to one of us in the radiation oncology department and just hear about what radiation really entails. I think most patients find that it's a much better tolerated course of treatment than what they envision coming into it. And that's one of the great things about our breast clinic. We as radiation oncologists are present, we're there. Any patient that has any question about radiation or a desire to speak with a radiation oncologist just has to request it, and we're happy to meet with them.
Thank you. When everybody goes pink for October, the color represents unity, it represents hope. And it's just so amazing to talk to all of you and listen to the things that you have to say and share with our public and our community. Such important and vital information. Before we close out of here this evening, I want all of you to give, the audience and the viewers, your thoughts on this month, the importance of education and awareness, and just talk about the most important message you want our viewers to take away from this evening.
So I will start. Again, obviously October brings all of this to the forefront. But in my world, every month is October. Breast cancer is kind of front and center. The numbers are anywhere from 1 in 7 to 1 in 8. And that means that if you have 8 friends, statistically, at some point over your lifetime, you may be facing this, or one of your friends will be. But the good news is that is a diagnosis. That does not mean that those people are going to die from breast cancer. And that is our goal, is to create a situation where none of those people die from breast cancer, that you have your treatment and you get back to your life and you put that diagnosis, in your history and on your back burner, and you move forward with your life and don't have to worry about it. But in order to have that happen, the earlier we know about it, the more options we have, the better treatment we have, and the less likely you are to have this be a cancer that negatively impacts your life expectancy or your survival. So it is super important to realize the commonality of this, and that just because most people who are diagnosed do not have a family history. Most of these are sporadic, and so really doing the screening, if you find something, get it checked out, are super important. I'll hand it over to Dr. Evans.
I agree with that, but one thing, I kind of go around preaching, like she said, every month for me is October as well. And I can't stress enough the getting your mammograms. Anecdotally, I'll see a lot of patients that are like, I didn't get my mammogram last year, and then there's a new diagnosis. I don't think that happened because they skipped their mammogram, but like Dr. Blank said, the earlier we find this, the more options are for treatment. So early, getting your routine screening, annual mammogram.
I would say, in addition to getting your mammogram, which definitely is in my top 3 list, don't avoid medical care because you think it's unaffordable or you're under or uninsured. There are resources available to you. Don't wait too long to seek medical attention. Every day we see patients that wait sometimes several years. The cure rates are significantly higher for earlier stage breast cancers. And thirdly, I would say, consider the lifestyle issues. What can you do to modify your risk factors for breast cancer, for other cancers, for cardiovascular disease, for all these causes of morbidity and mortality that we're facing nowadays? So diet and exercise, please look at how you're taking care of yourself.
Thank you. Dr. Syed, Dr. Perez, just close out important notes for our viewers.
I would just echo the sentiments of my colleagues. Surveillance is key. Take control of your health. We all lead busy lives, and I know sometimes we kind of deprioritize those things. But this, October is a good reminder that we sometimes need to take a few minutes for ourselves and prioritize our own health.
And I would agree, the key to this is catching it early. So if you see something or feel something in your breast, if you haven't had your mammogram yet, please go get it so that you don't delay your diagnosis. If you're not sure about reconstructive options, just ask for a consultation so you can ask about them. It's perfectly okay to come talk to us and decide that you don't even want to do reconstruction. The idea is just to be well-informed so you can make good decisions.
Well-informed to make good decisions. I think that's the perfect note to close out on. I want to thank all of you for your time, and thank you everyone who's tuned in to this insightful discussion. I'm honored year after year to come back and host it. I know more people than I care to admit who have been impacted by breast cancer, not only family, but friends as well. If you're interested in learning more about breast cancer, the incredible care offered at TMH, and more ways to raise awareness during Breast Cancer Awareness Month and year-round, you can visit tmh.org/GoPink. You can also learn more specifically about the Walker Breast Program by visiting tmh.org/Walker Breast Program. And lastly, as mentioned time and time again, don't forget one of the biggest weapons you have against breast cancer, your annual mammogram. You can request your annual mammogram appointment online at TMH's Sharon Ewing Walker Mammography Clinic by visiting tmh.org/mammogram. Again, thank you all, and we hope you have a great rest of your evening. Looking forward to continuing to watch the city go pink for Breast Cancer Awareness Month. But as Dr. Blank mentioned, not only for those going through it, but those who support it so closely, breast cancer awareness and education is not just in October, it is all year long. So thank you all for joining us, and have a great evening.
Thank you.
Thank you.
Thanks.